Hello, good morning, good afternoon, and good evening to all the speaker chairs and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honorable guest from Barcelona, Spain, Professor Alberto de Soma. Professor Alberto de Soma is a staff neurosurgeon at the Hospital Clinic de Barcelona and Professor of Human Anatomy at the University of Barcelona. He coordinates the Surgical Neuroanatomy Laboratory of the University of Barcelona, where in recent years, different articles related to mini-invasive endoscopic anatomy to the cranial base have been published. Dr. De Soma has been an invited speaker, professor and at several important world-renowned institutions like Will Cornell University in New York, United States of America, at Münster University, Germany. He also a noted author with over 55 international peer-reviewed papers and different book chapters. We are extremely grateful to him for accepting our invitation to be the speaker of our webinar, and he'll be talking about transorbital surgery to the skull base, philosophy, anatomy, and approaches. The speaker for the second session of today is our honored guest from India, Professor Deepak Agrawal. Professor Deepak is professor in the Department of Neurosurgery, All India Institute of Medical Sciences, New Delhi. He did his fellowship in pediatric and endoscopy neurosurgery at Vancouver, Canada. He has been trained under Professor Paul Steinbock for the pediatric neurosurgery and endoscopy neurosurgery. They have received training in gamma knives at the AIMS, New Delhi, and have been given GK therapy to more than 500 patients. He is also trained in serotatic and imaging-guided neurosurgery. He is also a noted author with several publications in various peer-reviewed journals. He was the recipient of the CNS, CSNS, YNS in the year 2008. He has been the editor-in-chief of the Neuro Journal of Peripheral Nerve Surgery, JPNS, since 2019, and editor-in-chief of India Journal of Neurotrauma, IJNT, since April 2019. We are extremely honored to have him today at our webinar, and he'll be talking about gamma knife newer indications. The chair for the first session of today's webinar is our honored guest from Korea, Professor Do Sik Kong. Professor Kong is the professor of neurosurgery at the Samsung Medical Center, Sunkunkwon University, Seoul, Korea, South Korea. Dr. Kong performs the innovative surgical technique, including the endoscopic, endonasal, and transorbital surgery for complex brain, tumor, and image-guided keyhole, endo, and micro surgeries. Dr. Kong is now an active member and president of the Korean Society of Endoscopic Neurosurgery. His research work has focused on development of innovative and novel skull-based and endoscopic approaches. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The second chair for the second session of today's webinar is our honored guest from United States of America, Dr. Carolina Benjamin. Dr. Benjamin is an associate professor, University of Miami and Jackson Memorial Hospital System, Miami, Florida. She is also a director of resident education, Department of Neurosurgery, University of Miami, Florida, and also the director of Center for Advanced Radiosurgery, Sylvester Cancer Center. She has published several books and monographs, as well as several noted articles in various peer-reviewed journals. She has also received several awards and honors for her outstanding contribution to teaching in neurosurgery. We are extremely grateful to her for accepting our invitation to chair the session of Professor Deepak Agrawal. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I would like to welcome both the speaker and chairs and the audiences to this online platform of ACNS webinar. We are a warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on WeChat channel. With that introduction, I would like to hand over this podium to our first chair, Professor Do Sik Kong. Professor, please.
Hello, everyone, and good morning, good day, and good evening. Ladies and gentlemen, it is with a great pleasure and honor that I introduce to you today a distinguished expert in the field of endoscopic transorbital surgery, Dr. Alberto de Soma. Dr. Disoma is a renowned authority in the realm of the endoscopic transorbital surgery, a groundbreaking approach that has revolutionized the landscape of minimally invasive surgery. In my personal experience, I started my transorbital work based on his distinguished and inspirational anatomical research work. His inspiration and perspective for the transorbital surgery has given to me many inspirations and impressions. I trust that his work will give us new insight and knowledge and impressions with these lectures. As a moderator, it is my privilege to introduce Dr. Alberto Disoma, an exemplar of excellence, innovation, and compassion in the field of endoscopic transorbital surgery. Please join me in welcoming him to this esteemed gathering as we eagerly anticipate the valuable insight, knowledge he will undoubtedly share with us today. Dr. Disoma, are you ready?
Thank you. Thank you so much, Professor Kong. Thank you so much, all colleagues, for this kind invitation and presentation. Very honored for me to be here this afternoon with you. So I will share my screen. Please let me know if, can you see the presentation? Okay, can you see the presentation?
Yes, bro.
Okay, thank you so much. So I will talk about transorbital surgery and with three main blocks related. The first one to philosophy, I mean, why we are talking about transorbital surgery today. The second block is related to anatomy, and the final block is related sure to clinical application. Dr. Kong, you want to say something? Or it's okay? Everything is okay? Okay. Okay, so
I'm sorry. Go ahead.
Great. So let's talk about why transorbital surgery to the skull base. So transorbital surgery to the skull base, in my opinion and the opinion of Barcelona group, if we think about endoscopic minimally invasive surgery, we think about endoscopic endonasal surgery, right? So endoscopic endonasal route is like a midline port to the skull base. If we think about some idea to don't cross the cranial nerve, so we say that we can say the endonasal route is a great mid-port to the skull base, even if it's possible to push the boundary laterally, but I mean, it is maybe demanding technical difficulties or complication that may happen. So if we look at the craniofacial anatomy, we can see that we can get the skull base from the midline endonasal port. We can also extend from to midline to the lateral part of the skull base from the nose, sure, or we can open another gate. That's the philosophy. That's the base of the at the beginning in our experience of the transorbital port to the skull base, just to open a port directly to the lateral skull base. So we published this study last years related to the skull base area that can be reached through the nose, that can be reached through the orbit, just to express this philosophy. So you can see these are the areas of the midline of the skull base midline that can be reached through the nose, and this one are the one that can be reached through the orbit in green. So you can say that the orbit, through the orbit cavity, we can reach this part of the skull base through the nose, the midline, and we can also combine the two parts. This is the way that we treat selected patient with transorbital alone or with combined technique I will show you later. So this is the first issue. The second thing, or philosophy thing that I will share today with you is why transorbital surgery today. Today, because if we look back at the literature, there has been a great improvement or number of publications during the last years. If we look back at 30 years ago, there would be those related to transorbital lobotomy or experimental studies, but the great the things that really changed probably the philosophy of transorbital surgery was the publication by Dr. Mo that put the endoscope inside the orbit cavity. So thanks to this, a great number of publication and case series and anatomical studies appears, and there's been a peak in citation in just 3 or 4 years ago. So especially thanks to the case series published by by Professor Kong and this group. So this is the philosophy. So if this is the philosophy, this is the reason why we are talking about transorbital endoscopic surgery today, the first thing to do, and I'm going to the second block, is the anatomy, is try to understand the anatomy of the transorbital endoscopic approach. So to do so, we try to systematize, to schematic, to put into some phases the approach. This is just a didactic things that I learned from my mentor, Professor Capabianca, that when he expressed and he shared the endonasal surgery to all over the world, he always said the three phases: there is a nasal phase, the sphenoid phase, and the cellular phase. And then the reconstruction is quite the same. So we have an initial phase that is the skin phase. Then we need to create a space. There's a working space. Then we need to remove the lesion and to reconstruct. So there's four stages that I would like to share with you. So the first one is skin phase. We have a lot of possibility to enter the orbit cavity with the endoscope with a great amount of a number of skin incision. This is a book published by Dr. Dallan related to different skin incision that can be used all around the orbit. We prefer to use a superior eyelid approach. This is the most used procedure in the skull base community, and above all is a hidden scar in the eye. As you can see here, when the patient is with open eye, this scar is practically hidden. So my colleague and friend, Dr. De Notalis, called like ghost surgery. So this is the skin phase we use to mark the skin at this level, 8 millimeter at the orbital at the palpebral rim. We use a monopolar Colorado, very low intensity. So with the cut at 7 or 8, we cut the skin. Once we cut the skin, we saw the very important muscle that is just below the skin layer. This the orbicularis oculi muscle, the palpebral portion of the orbicularis oculi muscle, as you can see here. So this muscle need to be spared. So you spare this muscle with the Colorado. With coagulation or cut, mainly with coagulation. So you spare the muscle, and the layer below, that is the white plane with the levator tendon, must not be entered. And once you get this layer, we put the stitches below and above, and then we get to the lateral orbital rim. At the level of the lateral orbital rim, we cut the periosteum. As you can see here, and this is the bone, we cut straight down the periosteum, and then we dissect the periosteum and periorbital layer just to enter inside the orbit cavity, as you can see now. So we enter this part. This is a virtual space. We just detach in this avascular plane. The periosteum continue with the periorbital inside. So we have all the lateral orbital wall here. So this is the situation where we end the skin phase, as we generally do with our oculoplastic surgeon at our institution. So this is the spatula pushing the periorbital medially. This is the endoscope. These are the instruments in this triangular and endoscopic concept that we use in the nose. Is quite the same. So the second step of the procedure is to create a space for work, because it starts like from the nose, but from the nose you have like air inside. In the orbit you do not have air. It's a virtual space. We need to remove bone. So it's very important, the bone anatomy. So this is the inferior orbital fissure, the superior orbital fissure. The drilling is starting at the level of the frontozygomatic suture. You need to remove the zygomatic bone, the orbital portion of the zygomatic bone. And this is the V structure that appears that correspond to the greater sphenoid wing. So the ventral and vertical portion of the greater sphenoid wing. We are unlocking this part of the skull. So we continue the drilling at these sides with this V pointing at the inferior orbital fissure. I will show you a video later. And that is the phase of the working space is created. So, and you can see also now in a cadaveric space, in a cadaveric specimen, this is the superior orbital fissure, the inferior orbital fissure, the temporal muscle here, and the V-shaped structure that correspond to the greater sphenoid wing. I think that we are now we are doing in this, our surgery now is to remove also the lateral orbital rim. It's an optional thing that gives you a more lateral approaches and entry and a little bit more space. As you can see here, this is an intraoperative 3D CT scan that gives you the idea of removing the lateral orbital rim. Can you can achieve. So this is a case. You can see the lateral orbital wall, the periorbit, some zygomatic fascial bundle that can be coagulated, so related to the inferior orbital fissure. We do it with the foot pedal. So we just cut inferiorly and horizontal at the level of the inferior orbital fissure, and then superiorly, just superior to the frontal zygomatic suture that is here. We already placed a screw bar for reconstruction at the end of the procedure. And so this permits you to have a little bit more of working space and, above all, a more lateral entry to the orbit cavity, but the concept is the same. So skin phase, working space have been done. So we need to get now to the lesion. But before presenting some clinical cases, let's go ahead and review some transorbital anatomic pillars that can guide you to different structures that can be reached through the orbit. So these are the transorbital pillars. As you can see, this is the lesser sphenoid wing that continues medially and deep with the anterior clinoid. This corresponds to the sagittal crest in relation with the foramen rotundum. This is the optic canal. This is the superior orbital fissure, and then the middle cranial fossa floor, and at the end the anterior petrosectomy. So this is the working space that we get. As you can see in this drawing, this is the skin phase, this is the working space done, and these are all the transorbital pillars. So transorbital pillar also in a reconstruction, as you can see here in blue, the lesser sphenoid wing, the anterior clinoid, the sagittal crest, the middle cranial fossa floor, and the petrosapex. So let's review the anatomy of these three medial structures. As you can see here, this is a transcranial perspective with the lesser sphenoid wing, anterior clinoid, and the optic canal with the internal carotid artery here. This is a classic transcranial perspective in this 3D brain lab reconstruction, as you can see here. But what about if we move this view from a ventral perspective? Where are the lesser sphenoid wing, the sagittal crest, and the anterior clinoid? So the anterior clinoid is placed here. As you can see here with the scroll, we perform this virtual drilling. This is the V structure of the greatest sphenoid wing. This is the sagittal crest. That's the anterior clinoid that continue medially the lesser sphenoid wing. Sagittal crest, foramen rotundum, anterior clinoid, optic nerve. So let's review this video, this anatomic video. This is the skin phase, the orbicularis oculi muscle, the weekend split, the white plane below. We go laterally to the lateral orbital rim. That's it. That's here with nerve navigation, cut the periosteum, dissect the periosteum and the periorbita, enter the orbit cavity. So the first structure very important to check is the inferior orbital fissure. We are here at this level, the inferior orbital fissure. So we can start drilling at this level and then check for the superior orbital fissure. So we are right, we are in between the inferior and the superior. So we can proceed with working space and discover the temporal fascia and muscle. So you can see now this V structure that is created. You can see the V structure here pointing at the inferior orbital fissure. Here is the superior orbital fissure. We have the periorbit, the temporal muscle here. So we have the lesser sphenoid wing here, frontal bone, and here we have greater sphenoid wing with the temporal pole. So if we move this section, this is the temporal pole. This corresponds to the sagittal crest that we can see here in this neuronavigation specimen, navigated specimen. So we remove the lesser sphenoid wing, the sagittal crest, then we cut the meningorbital band that will guide us to the most medial part of the lesser sphenoid wing, that is the anterior clinoid. So you can see here the base of the anterior clinoid, this coronal scan navigated, so we can drill up and remove from an extradural fashion the anterior clinoid, as you can see here. So these are the structures that can be seen, and you can also open the dura and see the intradural perspective, third cranial nerve, internal carotid artery. So we are detecting, we are discovering this area that corresponds to this. There is a very important, interesting publication very few weeks ago by Professor Do-Sik Hong, Shan-King Hong, related to the approach to the anterior clinoid processing of the canals. Is very, very interesting to see. I suggest you to see the video related to this fantastical article. So the other structure together with this is the sagittal crest. The sagittal crest is the last part of the greater sphenoid wing that you can unlock, and it permits you to to skeletonize the meningoorbital band, and so to perform an interdural dissection of the lateral wall of the cavernous sinus. This is a right side, is not a left side like the previous video. So you can see here the sagittal crest has been removed, and this is all the way down the interdural dissection of the cavernous sinus, and this is the extradural part. This is a wonderful publication very few months ago by Professor Schwarz related to this. And the lesser sphenal wing. If you remove completely the lesser sphenal wing, you can get directly to the dura covering the lesser sphenal wing. You can open the dura there, and then you can discover the Servian sister with the middle cerebral arteries. You can see here, this is the bone anatomy, and this is cadaveric dissection. So we talk about the three first transorbital pillar. Let's go ahead and see the other two, that is the middle cranial fossa floor and the petrosapix. So once again, the 3D reconstruction from a transcranial perspective, showing the internal carotid artery, the gastrian ganglion, the superior sagittal sinuses, under sinuses, and 7 and 8, brainstem, cerebellum, tentorium here. So in temporal lobe, if we see the petrosapix and middle fossa from a transcranial perspective, this is the classic view of the Cavase approach. You see here the petrosapix, the anterior petrosectomy that can be done. This is another view from a possible retrosigmoid approach. But what about if we want to see this anatomy from a ventral perspective? So once again, let's do the model in a ventral perspective. Let's do the scroll. It's always the same. So sagittal crest, anterior cranial here, foramen rotundum is here with the V2. So you can drill down all this part of the middle fossa up to V3. I will show some video. This is the middle meningeal artery, the GSPN, 7 and 8, in superior petrosal sinus, and the tentorium. So the petrosectomy from the transorbital perspective can be placed in this part that correspond to the Cavase triangle. So after cut the middle meningeal artery, this is the petrous internal carotid artery. This is the perspective of the petrous bone. So let's go ahead and review the same cadaver that we performed the anterior craniodectomy. So you can remove the lateral orbital rim to achieve more lateral dissection and drill removal and drill of bone. So we can drill the middle cranial fossa floor here. This corresponds to the crista ovale. We can dissect the cavernous sinus in an interdural and extradural fashion, as you can see here. So we can see now the third cranial nerve, the fourth cranial nerve is here, V1, V2 can be placed here, and then posteriorly we can see V3 in an extradural plane that is outside the lateral wall of cavernous sinus in the gastrian ganglion. Cut the middle meningeal artery, and then we can go posteriorly to show the petrosapix. So we can perform the petrosectomy, as you can see here in the neuronavigated scan, the petrosectomy just superior to the petrous internal carotid artery, and then you can get to the posterior fossa. These are images of the posterior fossa, internal acoustic canal, cranial nerves, Meckel cave, and then you can also coagulate or clip the superior petrosal sinus in order to augment the exposure of the tentorium and cut the tentorium in order to show the cerebellum and also the fourth cranial nerve. So it's very important to drill down the middle fossa floor. This permits you, this is a clinical case where we remove all the way down the middle cranial fossa floor to achieve the petrosapix. You can see here the sagittal crest has been removed. We dissect the temporal lobe extradurally. So there is a lot of bone that can be removed safely here. So this is a left side. So temporal muscle is placed here and the spatula here. So this is V2 now. We are performing an interdural dissection of the cavernous sinus and extradural dissection. This is V3. This corresponds to the crista ovale. So we can get posteriorly to the petrosapix, as you can see here. This is temporal dura. And so we can remove this part of bone to access. This was a case of petroclavian meningioma. I will show some cases that we do combined with the endonasal route. So that's meningioma in the posterior fossa. And you can see here some instrument from the nose and combination of two. I will show you later some cases. You can see the suction tube here and the ultrasound aspirator from the orbit. So that was lesion removal. I mean, the 5 main transorbital pillar So we get the skin phase from the superior eyelid, we get working space, then we get the 5 transorbital pillar, the lesser sphenoid wing, the anterior clinoid, the sagittal crest, the middle cranial fossa floor, and the petrous apex. Let's explain the reconstruction. It's quite the same in all cases, and then I will go through the final block, that is clinical application. So reconstruction we do with a multi-layer autologous material. First of all, fat graft to fill the dead space and contact with the dura, and then we put tissue coil, fibrin glue, in order to stack this reconstruction inside, and then we can use a dura substitute if needed, or we can put some other fat graft in order to avoid enophthalmos. But very, very important is to close also the layer of the periosteum here at the level of the lateral orbital rim, and also the skin muscular flap with continuous prolapse. This part is generally done together with the oculoplastic surgeon. We put a great amount of fat. We know that after a few months, this fat will be reduced in volume. So let's go to the last block. We see the reason why we are talking about transorbital surgery and transorbital endoscopic transorbital surgery to the skull base today. We saw all the possible anatomy, very reduced and very straightforward. It would be okay. And then let's go and see some clinical cases that we treat. And I will try to show the clinical cases together with the transorbital pillar concept in mind. So one of the first cases I wanted to show is a sphenoorbital meningioma. So to review once again the 3D scan, you see here the inferior orbital fissure. This is the case. It's a lady with the esophthalmos. There is an important hyperostosis of the lateral orbital wall. You see the V that is created here, pointing at the inferior orbital fissure. This is the anterior clinoid, and this is the sagittal crest. This is the lesser sphenoid wing. This is all the perostotic bone. This is the middle cranial fossa floor. So here we have a lot of transorbital pillar, not the petrous apex. Where is placed the tumor? The tumor is placed here. So we will have the first part, that is the approach, and the other part, that is tumor removal. So here we have also the relation with branches of the middle cerebral artery just posterior to the tumor in this reconstruction. So let's go and see the surgery. This is the lateral orbital rim, the sphenoorbital suture, the frontozygomatic suture, and here we see some branches of the zygomaticofacial nerves and artery, the inferior orbital fissure. We check with the neuronavigation. We remove the lateral orbital rim in this case, and we can go ahead and drill all the way down the bone, the perostotic bone in this case. So this is the temporal muscle. You see some branches will be coagulated. This is the V pointing at the inferior orbital fissure. It's here, right side. The spatula is placed here. So we drill down, and then superiorly at the level of the frontal bone. Then we go ahead up to the temporal pole that is invaded by the tumor in this case, and we go superiorly to the lesser sphenoid wing. So we continue the bone approach. We are going superiorly at the level of the lesser sphenoid wing. As you can see here, we are at the level of the lesser sphenoid wing, just between temporal and frontal lobe that is stuck by the tumor in this case. Then we go inferiorly at the level of the middle fossa floor, as you can see here. So this is the tumor, is in middle fossa floor. With neuronavigation, you can see that we are just at the inferior border of the tumor. Then we go laterally at the level of the most lateral part of the lesser sphenoid wing and peterion. So you can see here we are lateral at this level in the inferior part and the superior part of the tumor. And at the end, we will go to the most medial portion and transorbital pillar that are the base of the anterior clinoid. This is the coagulation of the meningorbital band, coagulation and cut of the meningorbital band. So you can see here the base of the anterior clinoid. This is a perostotic, also in this case, as you can see, we are here. That's the base of the anterior clinoid. And then medially, but inferior to the meningorbital band, the sagittal crest. So this is all the exposure that we get you can see here the sagittal crest and foramen rotundum. So all the exposure that we have of this sphenoorbital meningioma. So once you get that, it's like a convexity meningioma, as my chief, Dr. Ensegnat, said. So we just put the holder in the endoscope, we sit down and we open the dura, and with ultrasound we can remove, dissect the back, and all the things that we generally do with the convexity meningioma. This is the Sylvian cistern here. So we dissect from here the back, protect the branches of the middle cerebral artery with the suture, and then coagulate the border of the remaining lesion. So this is the post-op. It's quite good. The patient is okay. And we published this series along with other groups that published a series about the transorbital approach for sphenoorbital meningioma. And then this is another case. It's a middle fossa meningioma, sphenoid wing meningioma. And you can see here, this is the MRI picture. So once again, this is no hyperostotic bone, but it's quite interesting for the dissection of the middle cerebral artery. You can see here, this is the tumor, temporal muscle, and you can see the tumor in straight relationship with branches of the middle cerebral artery. Then this is the video. So you can see here the video. It's quite the same. The approach is quite the same. We coagulated the dura, opened the dura, and the bulking. And this is the interesting thing. Is it's just like microsurgical dissection of the arachnoid Sylvian cistern from the tumor, and removal of the tumors. You can see here the back dissect, and you can see dissection from the middle cerebral artery of the tumor. And also in this case, we remove the lateral of the rim, and this is frontal lobe, temporal lobe, and middle cerebral artery. So it's quite good, the post-op. So and the patient was fine. This was the craniectomy, the three-dimensional reconstruction of the bone removal that we get, temporal muscle, and this was all the way the bone removal that we achieved. So stage 5 and other cases, in stage 5, we now combine the transorbital approaches with the endonasal approach, as I said before. So we, in this case of chondrosarcoma in a young lady, we get the lateral part through the transorbital approach and the other part through the endonasal corridor. So let's review the 3D anatomies. It's periorbit and temporal muscle. This is the approach that we can get. It's inferior orbital fissure, sagittal crest, middle cranial fossa floor, less sphenoid wing, and anterior clinoid. We need to remove all the way down this block in order to show from a transorbital perspective the temporal dura and the tumor. And then the approach will be combined with the endonasal in a simultaneous fashion in order to remove this part of the tumor and then to connect the two approach and remove the tumor. So this is a transorbital port. This is the approach. It's quite the same as I showed you before. Temporal muscle, the V structure, superior orbital fissure, inferior orbital fissure, temporal muscle once again. So we go ahead up to show in the center of the V the temporal dura. So we can go fast and they show all the dura of the temporal lobe here, middle cranial fossa floor is placed here, sagittal crest, less sphenoid wing, and anterior clinoid. So we go ahead very rapidly. Okay, this is the less sphenoid wing. You can see here, frontal lobe, temporal lobe, lesser sphenoid wing that goes medially to the base of the anterior clinoid. So we remove all the way down the lesser sphenoid wing. It's very important, this part of the approach, in order to expose the tumor from the transorbital perspective. So and now we are going to the base of the anterior clinoid, as you can see here. And then the last part of the sagittal crest, so we can show the anterior border of the tumor here. We remove the sagittal crest and the tumor is here, the temporal dura is here. Meningorbital band is placed here. So we just now coagulate and cut the meningorbital band and enter into the tumor. So we enter into the tumor from a transorbital perspective, as you can see here. So it's a very suckable tumor with a chondrosarcoma. So just with aspiration, we were able to remove it from a transorbital perspective. The internal carotid artery is placed here. So we remove this part. Then we saw some pulsation of the internal carotid artery here. We check with Doppler and confirm the presence of the carotid. So very careful here. Go ahead with the secture and suction and remove all the way down this part of the tumor up to see the dura mater of the posterior fossa at the end of the approach. And then the same at the endonasal port is a transclavial approach, removal of the tumor up to the dura mater and to connection with the transorbital port. So this is the internal carotid artery inside the field. This is the endonasal view because the internal carotid artery just returned in its place after tumor removal. There was this part of the capsula that was very attached to the internal carotid artery, so we decided not to remove it, as you can see here. So the post-op is quite good, 92% of tumor resection, and she was sent to do radiotherapy. This post-op 1 month is very good, and the patient is fine. It's another case of petroclival chordoma. It's quite the same concept, and but very different. The idea when we are treating, we'll try to treat a petroclival meningioma from these combined approaches. So this is another case, but it's different from a petroclival chordoma, sure. So the idea can be treated by different approaches, and there are a lot of literature. I will not express a comment on this, but we tried the combined and simultaneous approach with the idea of follow the long axis of the tumor from a transorbital perspective or from endonasal perspective, and then to connect the two approach into the very end and posterior part and deep part of the tumor. So this is the endonasal view and the endonasal removal they want to get, the transorbital removal they want to get, and the connection area when the two approach will be. So the endonasal and transorbital corridor left side, I will skip the part of the approach. So here we have the section from a transorbital perspective, interdural dissection in order to show the tumor capsule. So we are here, this is the tumor, temporal lobe is placed here, this is the meningioma. We are in this part of the tumor. So we can start from the transorbital route to remove this part, while from the endonasal portion, in between the fifth cranial nerve, the basilar artery, the sixth cranial nerve is placed here, we can remove this part of the tumor. So at the end of surgery, the two approach will be connected at the posterior part, at the very deep part of the surgical field. You see instrument from the transorbital corridor dissect this part of the tumor, while instrument from the endonasal retract, so it's just like 360-degree removal of this petroclival meningioma. So at the end of brainstem dissection, our neurophysiologists said us that there were a decrease in potential, so we stopped the procedure, and we get an 85% of resection, and we have it's a meningioma grade 2 that was sent to radiotherapy. He had a 6 cranial nerve transient recovered, and this is the patient at 1 year follow-up. Now it's like 2 years follow-up. He is in good condition, and the MRI is stable. The same thing we apply to this patient, where we get a 90% of extent of resection. We experience a deficit in the 6 cranial nerves. So these were good cases because we followed the long axis of the tumor. We were able to connect the two approach at the very end of the surgical field. But there are some cases where we tried to do that, but the long axis was not respected, no connection area. We achieved a very poor removal from the endonasal and from the transorbital, even if the patient was with no deficit. So indications are still under consideration for transorbital route alone, combined approach, and so on. So it's very important to understand, in our opinion, complication, indication, and limitation of this approach. So backing upon our series, we recently published our complication related above all to the orbital outcome. We experienced 2 cases of an ophthalmos related to petroclival meningioma with BP shunt. We also head and persistent diplopia and oculopathic pain in cases of intraorbital tumor. All the other ocular symptoms like upper eyelid edema, diplopia, or periorbital edema were transient and decreases, say, at late ocular follow-up. So it's very important, in our opinion, to get back to our series and to show our results and complications from one side. From the other side, also study and continue to study anatomy. This is the reason why we have a lab at the University of Barcelona that is related to the Italian section of neuroanatomy, to the Spanish Society of Neurosurgery. There were a lot of fellows are with us during this year, and this permits to have a translational medicine that is just like bidirectional, meaning that from the lab we pass to surgery, and from surgery from lab again, and surgery once again. So it's a circle. It's not like from lab to the OR. So just to finish, next appointment we have in September here in Barcelona at our lab, and above all, the fourth international hands-on workshop endoscopic transorbital surgery directed by Professor Kong, Hong, and Cho. And last, this is a teamwork. It's not work of only one person. So I would like to thank my chief, Dr. Ensegnat, and all friends and colleagues that work in this approach. Thank you so much for your kind invitation. Thank you.
Yeah. Thank you for your nice lectures, Alberto. And I feel every time I hear your lectures, I feel his lecture is very intuitive and informative. And also, I have one question on the floor, as there is no questions. And of course, transorbital approach is a minimal invasive surgery, only requiring a small incision of the eyelid. But we have to know the advantage of transorbital surgery over the conventional transcranial approaches. And for example, for the beginners, and it takes very long time to start the transorbital approaches, and it requires a very long time of the surgery, for my experience. And then obtaining the wide working space is very difficult for beginners. Too small and too deep surgical field, dark field, is very challenging for the endoscopic surgeries. And as a result, many neurosurgeons hesitate to start these approaches. Alberto, how do you overcome these difficult challenges? And do you have any surgical tips to overcome this problem?
It's a great question. This is the reason why it was very, very difficult to start. You know, I started in anatomy, and then I met Dr. Ensegnat, and Dr. Ensegnat is a very expert endoscopic endonasal surgeon. So it pushed me. It pushed me to do that. And I think that the combination in between very well anatomic knowledge, and endoscopic techniques, not endoscopic transorbital, but endoscopic technique is the key to overcome such a limitation. I mean, if you are able to perform a pituitary adenoma, macroadenoma, intrasuprasellar macroadenoma, and then you know the anatomy of the endoscopic anatomy of the transorbital corridor, probably you can do a sphenorbital meningioma. I think that this is the key. Understand anatomy, dissection lab, and work together with be an expert endoscopic skull-base surgeon.
Yeah. And another question. And many surgeons ask me, how do you retract the orbit to minimize the retraction power? And do you use the dynamic hand-holding the retractor, or the fixator? With the fixator, you retract the orbit? And do you have any tip to retract the orbit and retraction power should be minimized?
This is the other great question. So we are working on it, and I hope I will present something in Korea in a couple of months. The idea is that once again, anatomy. If you detect the inferior orbital fissure and put your retractor just in the inferior orbital fissure, probably you have less power and less pressure over the orbit from one side. But you have to pressure, you have to push the orbit. So it's very, very important to check for pupil diameters every 20 minutes and above all at the beginning of the surgical procedure. But I think it's very important to probably develop some instruments related to this, above all for beginners. But that's the thing that you just said. If you begin with the surgery, just the initial step of the procedure are very difficult, probably you will not repeat this procedure. So I will do a craniotomy. But if you understand that it's just like at the beginning, and then the space is there, so probably we will help in this concept. Yeah.
Is there any questions? Yeah, Carolina.
I have a quick question. Alberto, that was a phenomenal talk. And I think, this is really a great example of how we need to continue pushing the limits. In terms of the sphenoid wing meningiomas, as we know, oftentimes that dural tail, even if it looks just a little bit thickened, rather than just being inflammatory, there's actually tumor cells there. Do you feel that when you're doing the transorbital approach, you can chase that sufficiently? Or do you ever feel like you're limited in getting that extra dural tail for those cases, in particular, where there's like sort of an en-bloc enhancement?
It's a good question. Thank you so much. I mean, it depends on the indication of surgery. So we are trying to indicate to do a surgery symptom related, but we know this phenoorbital meningioma, they recur, deficits, and so reoperation, radiotherapy. So the thing is symptom surgery. So the patient that we treat tend to have exophthalmos. So if you go to inside, you remove, very happy. Probably after 2 or 3 years, you need to reoperate, probably need craniotomy. So I think that if the philosophy is symptom oriented, probably the transorbital approach is indicated. Otherwise, if you want to remove everything, the dural tail and so on, probably a craniotomy. Sure. It depends on the case. Yeah.
And one more question: if you get recurrent, can you speak a little bit about reoperation? Like when you have recurrences, do you offer the transorbital approach, or do you automatically switch to to a craniotomy? What limits do you? What makes you make that decision of whether or not you go in and operate again through the transorbital approach?
So we are at the beginning of our surgical experience. So this was a question that me and Kim and Senyat, we had in the office. So should we do a craniotomy? How about fibrous tissue in the eye after surgery? I mean, we treated the 2 or 3 recurrent phenoorbital meningioma. There's not so fibrous tissue there, so you can get once again inside. So you can get once again inside, and once again it depends on the indication. If you want to remove everything, but if there is once again an optic nerve deficit or esophthalmos, we can get once again through the orbital with staged procedure, with combined procedure with the endonasal or transmaxillary approach that can be also used. We treat the cases of a recurrent phenoorbital meningioma went inside the infratemporal fossa with a combined endonasal to the maxillary and transorbital approaches. So it's an option.
Thank you so much.
Yeah.
Thank you, Vadir.
Yes. In my opinion, go ahead.
Okay,
Go ahead.
so sorry. Yeah, thanks, Professor Di Somma, for a very nice presentation. And I have 3 questions for you, Professor. If during your transorbital approach in the hidden area, would you prefer to remove more bone, or you prefer to use angle instrument or angle scope in the hidden area? Will you remove more bone, or you choose angle instrument or angle scope to see it? My second question, Professor, you show us the sphenoid wing meningioma. How do you remove the tumor if it's on the medial side of the optic canal, optic nerve? Would you use transnasal approach for that part? And last question, Professor, transcranial for clinoidectomy, anterior clinoidectomy, pneumatization of the clinoid process is cautious. But how about transorbital? Is it having the same problem, or is okay for pneumatization of the anterior clinoid process for your approach? Thank you, Professor.
Thank you. Thank you for this question. So the first thing is remove more bone. It's an option, but there is a limit. So there is a quite a limit. So we are now trying to study the possibility to get to the retroclavial area from the transorbital approach. So yes, you can remove the lateral orbital rim, go more medially, but there is some limitation. So if there is some limitation, probably yes, you can use angled scope and angled instrument to get to the retroclavial area with angled scope. The other question was about sphenorbital meningioma. If there is something that goes just medial to the optic canal at the level of the posterior ethmoidal artery, yes, we probably will select and combine the approach, but probably not in sphenorbital meningioma, because if you remove part of the lateral optic canal, probably you will have a release of the optic compression neuropathy only from the transorbital approach. And but this question, I would like to know the opinion about Professor Kong, and also about the last question, because we had experience with removal of the anterior clinoid in anatomy, and in surgery, with the base of the anterior clinoid, we do not select the cases for complete anterior clinoidectomy. So these are my answers, but I know that Professor Kong may add relevant infos.
So recently, we published a paper about the anterior clinoidectomy via the transorbital route, and the transorbital route starts from the below to the above side, and compared to the transcranial approaches. Transcranial approach is mainly focusing on the above, from the top to the bottom directions, and then it's more easier to find the optic nerve and optic canals, and then we identify the optic canals. We remove the clinoidectomy from the medial to the lateral side, and from the below to the above side, and then sometimes it requires a more excessive retraction of the orbit. That is major disadvantage of the transorbital clinoidectomies, but sometimes otherwise, and then it's more easy to find the optic canal. And then I think then successfully remove the anterior clinoidectomies, but still requires very challenging. So the large size tumor, I don't recommend it. And it's a very small size, compressing the optic neuropathies, and maybe good indications of the transorbital surgery. And my experience, and then in terms of the incidence, the spinoorbital meningioma is maybe the most common indication of transorbital surgery, but rather than meningioma, Benjamin said that many types of the meningiomas spread widely, and it's like the unplugged type of the meningioma, and maybe not be a good indication of transorbital approaches. For my experience, and then trigeminal schwannoma is much more good indications, better indications of the transorbital approaches. But still, when we accumulate our experience, removal of the lateral orbital rim, and we can go to the laterally and temporal side, more inferiorly, like the Alberto indicated, and then we can challenging to the more accessible the meningioma cases. Depends on. Is there any questions?
Professor Agrawal, you have a question from you?
I think that was an excellent talk, and basically we learned a lot. Transorbital approaches, we don't use them usually here for skull-based surgery. And I think based on your talk and what we saw, definitely it can be tried out, and it has immense scope, especially as we move towards more non-invasive or minimally invasive surgery. So I would say it is an excellent introduction where we can gain confidence to do these kind of surgeries. So thank you for that talk.
Yeah.
Thank you.
Thank you for Dr. Disoma's nice presentations. And then we're going to close the first lecture by Dr. Disoma. Let's go over to the second session. Dr. Benjamin, could you moderate these next sessions?
Yes, it would be my pleasure. So I think this session is actually perfect to follow what we just did, because I think what we're seeing here is that we have to think about the symbiosis and how the different approaches that we employ are really sort of have this synergy and allow us to really take care. We should think of skull-based pathology and problems as skull-based care. And that involves the transorbital approach, that involves the endoscopic approach. And I think what we're seeing now as well is that involves gamma knife. So I think this is a perfect segue into the fact that we need to be able to use all the different approaches in different ways. I think Dr. Disoma, Professor Disoma just showed these examples of how, we have pushed the limits with the transorbital approach. And then sometimes we need to know what our limits are and when to stop, and appropriately. Some of those cases required postoperative radiation for different reasons, be it residual tumor or a higher grade tumor. So I think this is a perfect segue. And Professor Deepak Agarwal is going to take us on a little bit of a journey of how the newer applications of gamma knife radiosurgery and how this has helped us in this symbiosis for skull-based care.
Thank you, Dr. Benjamin. So I'm sharing my presentation. I hope it's visible to all.
Yes, it's perfect.
So in this presentation, as Dr. Benjamin has already said, I'm going to be talking about a lot of things in which gamma knife is possible, and in which I think a lot of neurosurgeons are unaware of. We actually, starting from my talk, actually I'm a professor of neurosurgery at All India Institute of Medical Sciences, New Delhi. In India, the specific problem is that we have a limited number of neurosurgeons. I think that holds true for many countries like around us. And for a total of 1.5 billion people, we have 2,500 neurosurgeons. So there is a huge disparity in the care, neurosurgical care we can provide to our citizens. And that is why we need to explore options which can provide care consistently and with the standard of quality which is available elsewhere. And that care should be available now rather than 10, 15 years later, when possibly we might have more neurosurgeons per a million population or so. So in the routine care or routine gamma knife practice across the world, the first indication which comes to mind is metastasis, which is the most common indication, and followed by acoustic neuromas, meningiomas, as we saw the talk today also for sphenoidal meningiomas, smaller meningiomas or residual meningiomas. Gamma knife is an excellent option. Besides that, we have arteriovenous malformations and pituitary. So these are the standard indications for gamma knife. However, in this talk, I would like to take you all through the other possibilities which gamma knife has to offer. So I will not be talking on these standard indications, which we all are very familiar with, and I think with every neurosurgeon would refer these cases for gamma knife. So the first thing which I would like to talk about is pain. And we all know that the most common indication for doing gamma knife for pain is trigeminal neuralgia. And although the results are different in different hands, but usually 60 to 70% pain relief is there if the correctly selected subset of patients is given gamma knife. Many of them would fail gamma knife, around 30 to 40%, and have a recurrence of pain. Similarly, patients with who've been operated with MVD or who have been given injections or who are in drug therapy, they might fail their respective treatment and then be referred for gamma knife. What some of us would not be aware of is that gamma knife can be given twice and even 3 times in these patients. So we have, we have series from across the world, including from USA, that shows that patients can actually, if they have recurrence of pain, they can be given repeated gamma knives, even for the third time, with a huge, I would say, percentage of them having relief. And if you see these results in this slide, at 2 years, 35% of these patients had relief, compared to when, if you didn't do anything, they would all have pain. So now the question comes, even after third time gamma knife, you've tried everything, you've done MVD, you've done gamma knife, and the patient still has pain, what can be done? So in those patients who have absolutely intractable pain, and which you have exhausted all means of treatment, there is still another thing you can do with gamma knife, and that is you try some other, I would say, targets for lesioning. And we have a good target as the thalamus, and thalamic lesioning has been shown to provide up to 90% relief in those patients who have failed all other treatments. So that is, I would say, an amazing result for these kind of patients, in which who have also lost all hope, and in which we are also running out of options. So thalamic 140 grays, if you give to that, 90% initial relief, and the relief is usually, most of these patients have relief within days or weeks of giving gamma knife, of which 75% of these patients will continue to have relief at home. So I think that is something we should all consider in terms of pain relief for these patients. Another thing is cancer pain. And the cancer pain, metastasis pain, can be a huge problem to tackle anywhere in the world. And these patients who are basically on terminal care, the most important thing for them is to treat pain. And again, when you run out of options, gamma knife can be a panacea in these patients. If you look at the results, this was a study which was published some time back, and patients with bony metastasis. So we are not talking about anything related to brain. Bony metastasis, severe pain, bony pain, you give gamma knife to the pituitary gland and to the infundibulum, 100% pain relief within days. We have also treated one patient till now, and it is a dramatic, I would say, relief in the pain, which becomes almost zero. And the best part of this treatment is that the pain relief persists till death. So we are talking about patients who have a lifespan of 3 months to 6 months to 1 year maximum. In these patients who have all been followed up, there is 100% pain relief. And because it's a short duration thing, within a year or so, there are no hormonal dysfunctions. So I think it can be considered as an excellent alternative to other options for intractable cancer pain. Also, we get a lot of patients with other kinds of neuropathic pain, and some of them, like brachial neuralgias, who have very severe pain, resistant to all kinds of treatment. And you can have phantom limb pain, you can have pain secondary to a stroke, which results in severe debilitating kind of a pain. Other targets, like the lateral thalamus, can also be tried in these patients, and with good to excellent results. So, we give a very relatively high dose concentrated in the contralateral thalamus, and this has also shown to up to 75% to 50% relief at 2 years. So overall, for pain, I would say intractable pain, gamma knife should always be thought as an option and kept as a backup measure for these patients. If you look at the meta-analysis which has been done for pain, and I'm not talking about trigeminal neuralgia now, I'm talking about all kinds of pain, like neuropathic pain, cancer pain. So even in the meta-analysis, which is a fairly large number of patients, considering that nobody really knows about this modality, the meaningful pain reduction is in the range of 50% to 100%. So I think that is an excellent response to a treatment which is has minimal side effects, and the robustness or the duration of the pain relief is also excellent, in terms that for such a treatment, at least 30-40% will have continued pain relief at last follow-up. So again, I would reiterate that the gamma knife should always be thought. We have started doing it recently for cancer pain and chronic pain, and I think it offers an excellent alternative. In this cartoon, you can see the targets which have been selected for gamma knife. And what authors have found is that the more posterior you keep the target, the more lasting the pain relief is, although this is experimental, which brings home the point that more research is needed in this field to identify the targets, to have longer follow-up on these patients. And this all can be only possible if we do more patients, do more research on these kind of patients. Headache, again, who would have thought that gamma knife would be used for headache? So obviously not all headaches. You can't use it in migraine as of today. But, there is a subset of headache which is known as SUNCT, in which this is, the full form is short unilateral neuralgia form, cluster kind of a headache. In this, if we target the trigeminal neuralgia nerve and the sphenopalatine ganglion and give a high dose to them, dramatic relief in the headache has been observed. And it's even for cluster headaches, and cluster headache is relatively common, and there is good initial data to show that up to 100% of the patients will have initial pain relief, with the relief persisting in up to 40% of the patients at last follow-up. So this treatment has minimal side effects because giving gamma knife to the trigeminal nerve has been proven to be extremely safe, effective, and with minimal side effects. So giving this treatment to patients, I think, should be always considered in cluster headaches as well as SUNCT. Coming to tumors now, we have talked about the standard tumors which we give gamma knife. However, there are other tumors less known for which gamma knife may be either ideal or considered as a good choice compared to other modalities, starting with hypothalamic hamartoma, which is, I would say, some authors have even said that it should be the gold standard for gamma knife therapy. And although a lot of options are available for hypothalamic hamartoma, right from disconnection, surgical disconnection, to radiofrequency ablation, to endoscopic resection, gamma knife is also one of the options, and in which we can do two things. We can either disconnect it from the hypothalamus and target only the interface, or we can give the whole hamartoma a radiation dose, which is relatively less, between 15 grays or 20 grays. And we have treated our 5 patients in which we have long-term follow-up. And I would say the relief, symptomatic as well as the radiological relief, is in excess of 80% in these patients. So gamma knife therapy, and I will come to it later why I am espousing gamma knife for all kinds of tumors in preference of surgery despite being a neurosurgeon. So this is the targeting we have been doing. This is in our institution. This was a large sessile hypothalamic hamartoma. As you can see, we have not treated the whole hamartoma. So the inferior portion has not been treated. We have only treated the portion which is connecting, the stalk portion, which is connecting to the hypothalamus. Lymphomas. Previously, before we knew about the literature, we used to send the lymphomas for chemotherapy and possibly radiotherapy. However, especially the primary CNS lymphomas, beautiful results with gamma knife. If you look at the mean survival, the survival goes more than doubles, I would say, in the gamma knife additional group compared to if you just give pure chemotherapy. So again, I feel, and you're not, you are giving minimum radiation to the rest of the brain. So cognitively, because these patients may be sometimes young, sometimes not that old. So cognitively, these patients remain intact, which is a very important consideration in every individual. And I would say that gamma knife should always be added onto the regime of chemotherapy in PCNL. Here also you can see we have given this radiation to whatever enhancing portion we could see, and with beautiful results. Epidermoids. Now, obviously the first option for epidermoids is removal of epidermoid, but we have all faced with recurrence, one recurrence, twice recurrence. Sometimes it becomes very difficult, despite your best efforts, to remove the capsule from, I would say, structures which are intimately involved, like vascular structures or nerve structures. Like in this case, the basilar artery maybe was encased. And so after surgery, if you have residual, one of the options is gamma knife. So despite it being full of epidermoid cells, the cell lining is thought to get destroyed by the gamma knife. And although this tumor will remain like this, maybe for life, hopefully it will stop growing. So our endpoint is obviously not to decrease the tumor. Our endpoint is to stop it from growing. And we have treated 4 patients till now, and all 4 of them on follow-up, they have remained constant, whereas previously, prior to gamma knife, they were increased. So I think, again, the epidermoid should be, we follow up these patients, but it's better that we add gamma knife to our regime post-operatively. Interestingly, colloid cyst is never thought to be amenable to radiotherapy because it's a cystic colloidal material inside, and not thought to respond to gamma knife. But again, there are so many options. When you operate, you might be doing it endoscopically, you might be doing it open surgery. We all know the complications. I mean, as a neurosurgeon, you know that any handling of the fornices may lead to memory disturbances for these patients, which may be subtle but permanent. So in the best of hands, you can have complications. And if the cyst is small, very small, there is controversy to some extent that a very small cyst, less than 2 meters, should we be removing it, because sudden deaths have been reported in these patients. So general recommendations have that irrespective of the size, even the smallest cyst, they should be removed. Here again, we propose that gamma knife can be a good alternative, number one, as a primary treatment for very small cysts, which can then be followed up. Because now we again, the mechanism of action hypothesizes that the cyst wall gets destroyed, and so there is no accumulation of colloid material over time, although this is hypothetical. And the second option obviously is that after treatment, be it by surgery, be it by stereotactic aspiration, be it by endoscopy, we do for any portion which is remaining. And a lot of times, you cannot get a absolutely clean radiology. You have some remnants. We propose that gamma knife should be given to these patients also, as we feel that when you follow these patients for a very long time, the chances of recurrence become less. In GBM, we are the only group to have published a paper, recently, some 1 year back, in which we proposed that gamma knife can be given as primary therapy without external beam radiotherapy following surgery. So this was a landmark paper. Nobody else in the world had proposed this. Till now, the standard of care is that you give radiation therapy, which could be EBRT or any other radiation therapy, as early as possible, usually within 6 weeks following surgery. So gamma knife was proposed to be given as a booster dose in addition to the external beam radiotherapy. However, we propose that because standard radiotherapy takes 4 weeks or so for administration, and these patients usually are not that well, better that we just give 1 dose of gamma knife to these patients. And we did a relatively large study over 1 year, and it's been published, in which we showed that gamma knife was not inferior to external beam radiotherapy. It had the same outcomes compared to external beam radiotherapy. So I think that's a step in the direction where we can later say, depending on the results, that we can really do without EBRT. Also, another unique problem we face at our institute is that we have, because of the huge load of patients, we have a waiting times even for GBMs which may extend from 3 months to 6 months to even 9 months, depending on the size. And because of this issue, when we first see the patient to the time the patient is actually admitted for OR, the tumor might have grown manifold. So recently we have put in a study which is awaiting ethical approval, in which we have proposed that we should be allowed to give gamma knife upfront at the first time we see the patient, without any pathological evidence that it is based just on the radiology that it is a high-grade glioma. We give gamma knife, and when they get admitted, based on the waiting time, 6 months, 3 months, at that time we operate upon them and see how much the tumor grew or maintained and what was the pathology at that time. So this again would be the first study of its kind if we are allowed to go along with it, and really would set a precedent in terms of how far you can push the envelope in terms of giving gamma knife, like we do for meningiomas. A lot of time we give gamma knife for meningiomas without histological diagnosis, just based on the radiology. So we propose that similarly for high-grade gliomas, we should be allowed to do gamma knife, and then take the histopathology at a later date when they are actually admitted and operated. Vascular. Now, vascular, we have, we all know the indications, routine indications for vascular, and I said that was arteriovenous malformations, and to some extent, although controversial, carcinomas can also be given gamma knife. How many of us would actually believe that gamma knife would help in aneurysms? And in fact, I'm talking about saccular aneurysms. Animal trials, people have tried giving gamma knife, and lo behold, there has been a linear decrease in the aneurysm. So this was the animal model of the aneurysm which was created, and you can see it's a clear aneurysm with a saccular aneurysm which was given gamma knife, and there's a linear decrease in the aneurysm size following gamma knife, which is approximately 20% per year. So how would this translate to humans? Actual patients with aneurysm, now that this neurointervention is taking over almost all vascular surgery, where does gamma knife fit in? And again, you would be surprised that actually humans have been given, and these aneurysms are not with the flow related because of AVM or anything. These are pure saccular aneurysms which have been given gamma knife in the distal vessel, and the standard dose of 25, which we give for AVM, 100% obliteration rate, 100% obliteration rate within 2 years. I think this is a remarkable thing which sets the ground, for treating aneurysms. And we're not talking about obviously ruptured aneurysm, which needs to be treated by surgery or by neurointervention, but incidentally detected aneurysm, which have always remained an enigma, whether to treat, not to treat, what size to treat, less than 7 or more than 7. I think that debate goes into history. If we just treat the aneurysm with gamma knife, it will automatically obliterate as the data show. And it really opens up a new vista in managing these patients. If you have screening for these patients, for example, you can pick up the aneurysms earlier. And with patients undergoing screening more and more often, we, instead of coming with the rupture, I think the future will be that we'll be detecting these aneurysms, and multiple aneurysms can be treated simultaneously. That is again a beauty of gamma knife. So if you have very small berry aneurysm all across, because of whatever condition, gamma knife holds an exceptional promise in this era. Functional, obviously, we all know that, besides neuromodulation using deep brain stimulation, there are other methods, and radiosurgery like gamma knife has a role, has a proven role. However, it is out of favor in compared to deep brain stimulation. Again, coming back to our population, because, instead of blindly copying the West, and the costs are prohibitive for deep brain stimulation for our patients, gamma knife can be a beautiful alternative, because there's a huge population who is being deprived of treatment simply because it is unaffordable, rather than thinking of alternate treatments which may be equally effective, if not better. And this has been established beyond, any kind of doubt, that Parkinson's and essential tremor patients can really benefit from gamma knife. And you can see the huge improvement in MDS and UPDRS scores in these patients if the targeting and lesioning is good. And we need more research, we need more data. And there is no dearth of patients in countries like ours where gamma knife can be used in preference to expensive treatments like DBS. And obviously the naysayers and the people who are opposed to gamma knife will point out that it's a destructive lesion. There could be a huge amount of edema in it, and it can really have problems. Side effects are there with every treatment, be it DBS also, and gamma knife is no exception, obviously, because you're giving a huge dose of radiation to a very concentrated part of the brain. However, majority of the patients, more than 90% of the patients, will have excellent long-standing relief in their tremor and in their symptoms. So I think that is should always be considered. Patient selection is always important. And obviously, this is only for those patients who are debilitated and not responding to maximum drug therapy, who have multiple on-off syndromes. But there will always be a huge subset of patients who are waiting there for this kind of treatment. And I think it can be an excellent way to treat. OCD, we have in our institute, we have treated 3 patients with the OCD, and the excellent results. I mean, they had no treatment available following maximum drug therapy, and relatives were also running from pillar to post trying to find what else could be done. And we did a gamma knife capsulotomy, and first unilaterally, and when we gained confidence, we could do it bilaterally. The Vibox score falls from a max of around 34 to 10 within 6 months. And it remains like that, for with a median of 26 in our own series, it was for 2 years. So I think it is a treatment which again we are denying to our patients just because we don't have our colleagues on board, like the psychiatrists on board or the cancer specialists on board. And our own community is unaware that these options are available. They may be beneficial to these patients. Epilepsy, obviously, there is a level 4 evidence. Trials are lacking. We had the ROSE trial, which we had to end prematurely because of safety concerns. However, putting the whole, I would say, data in perspective, radiotherapy, specifically stereotactic radiosurgery, has been shown to be really effective in epilepsy. Yes, as you're giving a big dose to a big area of the brain and the temporal lobe, middle temporal lobe, there will be edema. They might increase seizures, but this is usually temporary. After the initial, you can see in this slide, this patient at the baseline when we gave, I didn't give, but one of our colleagues in a different institution. So this radiation, you can see the edema which increases and then settles down. So you have to give the patient around 12 to 18 months for things to settle down. But again, where I'm coming from, I'm telling you that epilepsy, when neurosurgeons for the whole population of India is just 2,000, epilepsy surgeons hardly 100. With a huge 2% of the population of any country will have epilepsy, of which another 10% will have drug-resistant epilepsy with all kinds of problems. You don't have the surgeons, you don't have the infrastructure, and you're not ready to even look at other alternatives. That is not the solution. The solution is to do proper research, look at alternatives, find solution for your own country and for your own population. And I think gamma knife fits the bill in this situation, where in the absence of, trained, because epilepsy workup itself, as we all know, is a huge challenge. It takes a lot of resources and money to get a proper workup done. Not available in most places. And this is a beautiful alternative for those patients. Instead of having 10, 20, 30 seizures per day, at least you're providing them some hope rather than just putting them off that nothing can be done and giving more and more drugs. Hydrocephalus. How many of us would have thought that gamma knife can be given for hydrocephalus? Now that is really amazing. But yes, people have done that. We have still not mustered the courage to give it. But this has been published, and what has been done is a stereotactic radiosurgical third ventriculostomy. Again, a beautiful thought that instead of doing a ventriculostomy, endoscopic third ventriculostomy, why don't you give a concentrated dose there, and it will make a hole in that automatically. And we have also put in a project for our ethics committee to allow us for patients with metastasis, with a limited life expectancy and who have hydrocephalus, to allow to do this procedure. So based on that, then I hope that we'll be allowed to further increase the scope of that study to other patients. Right now, we have patients with acoustics who come with, because of various reasons, come with hydrocephalus. We have patients who have pineal region tumors, again coming with hydrocephalus. So we are not treating the hydrocephalus, we are just treating the tumors with gamma knife right now. But it is possible that in future we might do both the procedures together. We treat the tumor with the gamma knife and we do a stereotactic radiosurgery for the hydrocephalus together. Again, the possibilities are limitless. We need to have an open mind, frankly, for these and elderly patients, specifically elderly patients, more than 70 years, 80 years of age, these population is rising. They're coming up with more tumors and all kinds of things. We all know that in neurosurgery, it is not the meningioma surgery which is most difficult. It is the shunt surgery which is most difficult, because the complication rate and the problems associated are so high that even the most experienced neurosurgeon would think twice before jumping in to do a shunt. So I think, again, I'm not proposing that this is the first line treatment. Obviously, this is experimental, but research should be done on it. Infection. Now, this is completely counterintuitive. Can gamma knife be used for infection and inflammation? And you won't believe it, but it has been tried in human patients. And here, this is hydatid disease. Now, hydatid disease is an extremely difficult disease to treat, especially if it is, in a racemose variety or a different kind of variety where it is conglomerate. It's difficult to take out. And you can see the huge amount of edema to this. Gamma knife, and a very low dose gamma knife, the same dose you would give to a caustic or to meningioma, you give that, And lo behold, the whole the edema has settled down. The whatever, again, nobody knows how it works. Most probably, what the hypothesis is that the chemicals which are released by the hydrated, which may be responsible for the severe inflammation, those might stop because of the killing of the hydrated because of them. But again, it's a hypothesis, but it works. So in selected cases, instead of just condemning the patient, this is a beautiful way to try it out and see the response. Langerhans histiocytosis. Again, we have somehow, when you review the literature, you find that all these kind of things were given gamma knife in the 1930s, not gamma knife, sorry, radiotherapy in the 1930s, 40s, which fell into disrepute, was stopped. And now nobody thinks of, radiotherapy as a treatment specific for Langerhans histiocytosis. Gamma knife can be a valuable, I would say, alternative, which you target this disease. It can really, because it's a eosinophilic granuloma, it's an inflammation in a way. However, with gamma knife, it responds, and they respond beautifully. So I think this gamma knife has opened our eyes, and you have to have. You cannot just say no. I will not think about it. This will not work for me. And as Lady Gaga also said, that unless half the people don't like your work, you did it wrong. So you have to remain committed to what you believe is right. Otherwise, you do the standard meningioma and acoustic neuroma throughout your life. So this was a paper we took out I think this year itself, where we proposed that for countries like ours, where the population, the neurosurgeons are less, and where the neurosurgical load is very high, we want solutions for our population now. We can't wait for 10 years, 15 years, 20 years for the resources to build up. I feel that gamma knife, and when I say gamma knife, I mean all stereotactic radiosurgery, in fact, all kinds of stereotactic radiosurgery, can be a panacea. If you look at the data, this is at our institute. So we were operating around 6,000 cases, 6,000 to 5,500 cases before the COVID came into the picture. So at that time, we precipitous drop. However, gamma knife continued to increase. And this year, after we got a new machine of gamma knife, which is, the latest iteration of gamma knife has that lightning plan, which really improves workflow. You can treat 10, 15, 20 patients a day. And I always say that once you buy a machine like gamma knife, it is wasting every second you don't use it, because the radiation is going out of that machine. Either you put a patient in it or is going waste. So it is a valuable resource which should be utilized to the maximum. We have our neurology rounds, we have a meeting with neurologists, and everybody is fighting, I would say, or arguing that if there is an AVM or if there's a small tumor, that it should be operated, or it should be embolized, or it should be for a vascular malformation. I would say any lesion which is amenable to gamma knife in any way, first should be tried gamma knife before we jump into things like surgery, especially like for AVMs. Because those, anyway, the resources are limited. There are so many patients waiting for surgery, so many patients waiting for neurointervention. Why we fight over the same thing? Because that is the simplest, that is the easiest. We should reserve all those cases for gamma knife, because then they can be treated easily. And we put in certain policy decisions at our institute, and we said, because it costs around $1,000 for gamma knife at our institute, and it's obviously free for poor patients. But we put in a simple thing that all MRIs for life will be covered in the initial treatment price. So this simple thing ensured, because the MRI cost itself is so expensive, most of the patients can't afford follow-up MRIs. This step ensured that all patients we can follow up almost 100% for life. because we are guaranteeing them all follow-ups free. And in case we want patient requires a repeat gamma knife for whatever reason, or for that repeat gamma knife is also considered, is put into the same treatment cost, first treatment cost. And we calculated, the staffing and the costs associated with everything for putting up a gamma knife machine in India. And you can see, and we were running it in 2 shifts, averaging 1,500 gamma knife procedures here. These were our estimates. And when you see the cost, it actually comes out to be around $7.45 million over 10 years. This is including everything, including every MRI for that patient, considering that we are doing follow-up MRI every 2 years for the next 10 years for these patients, and obviously for life. And when you see the life cycle costing and the revenue and the, and gamma knife I've taken as a prototype because it's the most expensive. If you take other machines equivalent, like there are some machines from China which we have no experience with, obviously they will be 1/3 the cost. So the cost advantage will be so huge, it's incalculable. So even if you're doing 1,500, you have a huge revenue so it's a net positive thing. And as I showed you in my first slide, that almost 1/3 of a neurosurgical department's caseload can be taken over by gamma knife. This is as of today. So easily 1/3 of the patients in a huge high volume department like ours instantly can be given gamma knife. And that would be the case anywhere else in India if you hypotheticate the whole thing. So obviously a huge, I would say, subset of patients, 1/3 of all neurosurgical patients as of today are amenable to gamma knife and can be treated instantly. The only thing we need to have is a machine and resources. Obviously, using telemedicine and using all the technology available, highly consistently we can treat these patients with the same level of care as would be available anywhere else in the world. So my submission is that there is immense scope for gamma knife research in India and everywhere else. We have a huge caseload. Possibilities are endless in terms of the indications, applications, and newer vistas. And finally, it's not that I'm totally bought on gamma knife. I'm saying that it's not a panacea, but it can be an excellent complement for any neurosurgical practice, especially in developing countries or semi-developed countries like us. Thank you so much.
Thank you so much, Professor Agarwal. Do we have any questions from the other panelists?
Yes.
May I ask 2 questions, Professor? Yeah, okay. Professor Somma, please.
Thank you. Thank you, Professor. Very interesting lecture. Just a question regarding, there are different other radiosurgical options. So what, like, for example, I'm not very expert in the fields, and our hospital not is a radiosurgical department up to now, but probably we will introduce it next year. It's very difficult to understand the best machine, or to fight with the economic department, by one or another. So what's your opinion, for example, regarding the other very famous, that is the ZAP today, I think. So it's so different. Do you think that indication and outcome may be the same or not? What's your opinion about? Thank you.
Yes, thank you, Dr. Somma. I think it's a very good question, which is always there. And I would say that there are 2 main differences when you choose a machine. One is, if you have the resources, provided your institute has the resources and a huge caseload. Like, for example, in our institute, we are doing 1,500 patients a year. A dedicated gamma knife machine makes more sense, simply because it is under the control of the neurosurgeons, and you can optimize the use much better. and it remains administratively, clinically underused. If you go for a machine like a CyberKnife or Zap, that machine automatically will be under the radiotherapy department, onco specialist, simply because that machine is capable of doing from head to toe all kinds of lesioning and is maybe more cost effective for the hospital, especially the financial division. So in that case, for most of the cases that will work. However, because neurosurgery will not be involved too much, our own experience is that most of the patients are not referred for Zap or for CyberKnife. And a lot of them, depending on the radiotherapist preferences, might not be given. They might want to utilize other machines more like EBRT, linear accelerators. So only a subset of patients may be put through this because of their own priorities. So coming to this first point, if you have a high volume load, Gamma Knife is the way to go. If you have a low volume load, obviously you should think of Zap or CyberKnife. The second thing is in terms of the precise delivery and the treatment. So in terms of I would say, the preciseness of the delivery, there is no equivalent of Gamma Knife. The radiation fall off and the quality and the sub-millimeter accuracy which you get with Gamma Knife, you cannot get with either Zap. Zap, in fact, they go to 1 millimeter. Gamma Knife, we talk about 0.1 millimeters. And similarly for CyberKnife, they go up to 1 millimeter. So although they might say they're equivalent, but this equivalence is how far you want to see it in terms of it. So if I have an option for my relative, I would prefer, if it's a big tumor, 1 millimeter or 0.1 millimeter doesn't make a difference. So like acoustic, large acoustic or meningioma or AVM, all three modalities are technically the same. But if you have a very small lesion, you want to make sure that you're targeting for functional neurosurgery, for all these kinds of things where you're making very precise lesioning, Gamma Knife is the way to go. So this is my take on the three machines.
Thank you.
I agree with that. The one thing I'll add to that too is the Zap is obviously very early on, like you mentioned, and a lot of the data, it's important to give patients the data of what we're doing. And a lot of the data really has been done on the Gamma Knife machine. So there's a paucity of data even with the LINAC accelerator. Yet people extrapolate the results as if it's the same modality. So that's a little bit something to be wary about. Is I think the important thing with the Zap will be to collect new data, right? It's the onus is on us. There's a new machine that if people are employing it, then they should definitely collect new data to see and compare outcomes.
Yes.
Go ahead. Any other questions?
Yeah, thanks, Professor Agrawa, for a very nice lecture. I have two questions, Professor. First one that regarding pain and functional, both RF radio frequency and also DBS claim to have property of neuromodulation. And there are also papers talking about neuromodulation with GK. So may you comment about this? Second question, Professor, regarding lesioning procedure. Now we have focused ultrasound as an alternative. What do you see the future of GK with the rising use of focused ultrasound? Thank you, Professor.
Thank you, Professor, for your questions. See, I would say all the modalities, including radio frequency ablation, including deep brain stimulation, and Gamma Knife have a role in terms of pain as well as other lesioning things. So when we talk about a specific patient, it depends on the patient's preferences, the doctor's preferences, and finally, the environment in terms of how much the patient can afford, what is the insurance, and what are the other modalities available. So for the vast majority of the patients who can afford, we would also offer deep brain stimulation or neuromodulation as the first line. And in case they fail that, then we can come to Gamma Knife as a destructive thing. So that is our procedure. However, for a lot of patients who cannot afford for whatever reason or who are not suitable, so we have to understand there will always be a subset of patients who are not suitable for general anesthesia, because of so many reasons. They may have cardiac issues, they may have other issues, which makes them contraindicated for deep brain stimulation. In these patients also, gamma knife may be very effective. Thirdly, I would go in a stepwise direction. I suppose if I'll give a very simple example, I would, for trigeminal neuralgia, we first try drug therapy. If it fails, we try radiofrequency ablation. We try balloon ablation of the trigeminal nerve. If that fails, then only the pain specialist will refer to you. If that patient had come first time to neurosurgeon, I would have advised MVD at the very first instance. If they fail MVD, then we can try repeat MVD. If they fail repeat MVD, then we plan gamma knife. Except when the patient is so scared of surgery that he says that I will not undergo surgery, I want only gamma knife. So there are a lot of patients who actually want that they don't be touched upon, they be given gamma knife, and we can keep giving gamma knife in these patients. For the second question which you asked was, sorry, I forgot the question. Can you just repeat?
On focus ultrasound,
yes,
competing with GK.
Yes, yes. So for focus ultrasound, I think it has a role. Right now, I feel it is industry driven because a lot of money is being spent on marketing it. Because obviously a lot of money has been put in building it, so they need to recoup the money, and it is extremely prohibitively expensive. If gamma knife is 1x, then ultrasound is 2x. So that's the amount of difference between the two modalities right now, and the amount of lesions you can treat with ultrasound is much less when you compare to gamma knife. So if gamma knife can treat 10 lesions, this can only treat one, because there's a very limited, I would say, portfolio of lesions which you can treat. So I think, yes, it has a place. It is a fancy way of doing gamma knife. I would still prefer gamma knife to anything, but it is still early days. Maybe in future you might have specific indications, and it obviously has some role, but in our setup, in our country, very limited. I would not propose.
Thank you very much, Professor.
I had one quick question for you. For the glioblastomas, it's that's a very surprising fact that people wait 3-6 months. So I understand sort of the desperate need for another approach. When you're doing your targeting, what do you target? Just the enhancing, or do you target the flare as well?
No, we just target the enhancing portion. That's a good question. And so there are two parts to it. The first part is, if we are doing gamma knife upfront, we have still, or we see a high grade lesion, we will target only the contrast enhancing part. However, post resection, when we are targeting a lesion, let's say the operative cavity, in that obviously they might never be, in some cases they might not be enhancing part, in which we target the operative cavity wall. So there might not be any flare signal intensity also. Irrespective of the flare signal intensity, we will target the whole cavity wall and the cavity itself to give gamma knife.
Great. Well, thank you so much. I think that was very incredible, impressive. I think we're very lucky in some countries where we have the availability of every modality to treat tumors and facial pain and everything else. And I think when resources are limited, we have to get creative, and the best way to sort of do that safely is collecting the data, which you're doing, and I commend you. It's a really fantastic job, and thank you so much.
Thank you so much.
Thank you to both our speakers and chairs. So we are closing the session now. On behalf of the Education Committee of the ACNS and the President, Professor Kokato, I would like to thank both the speaker of today, Professor Alberto Di Soma and Professor Deepak Agrawal, as well as the chairs, Professor Du Sik Kong and Professor Carolina Benjamin, for the time and support for the SNS webinar. I also would like to express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel, and today we have around 400 people who join us live. So until we meet again online on 29th of August, this is bye-bye from all of us. I thank you very much.